And welcome back to the Paramedic AF show. I'm Daniel.
And I'm Michelle.
And today we have a repeat guest who many of you saw. I did an interview with about 2 months ago, Christopher from the Blakery Content. And we decided we wanted to have a longer conversation and hang out for a little bit. So, Christopher, welcome back. Thank you for joining us.
Yeah, absolutely. Thanks for having me back. I've been looking forward to sitting down with both of you and chatting and just hanging out.
So, tell us a little bit about. I know we did the basic introduction last time, but just a quick overview of who you are, what you do, and let's get into your TikTok channel.
Okay. Yeah. So as you mentioned, I'm Christopher with the Blakery Content, and then the new edition of the Reducing the Pucker Factor podcast that's in production and rolling out soon-ish. My background, so it's hard to believe I'm 24 years into this. My very first day at the fire department was September 11th, 2001. And that was my first day of training at the fire department, and progressed. I did about 15 years as a firefighter paramedic. Uh, the last four of those, I was doing pediatric and neonatal flight medic while still working on the fire side, and then transitioned to nursing, where I worked in the pediatric ICU. And then I left peds and went into the adult world where I did level one trauma ER, surgical ICU, trauma ICU, neuro ICU, and then started flying as a flight nurse specialist, and had to take a step back, had to put family first, and had some family things come up. So I took a step back, did some travel nursing for a little while, and then ultimately made my way back as a peds and neo critical care flight nurse, and then ultimately back to, I was a peds EMS coordinator for a regional pediatric center, doing education only for a while. And then I got to that point where I was like, I need to decide, like, I've been non-clinical for a couple years. Like I either need to like fully get back in, or I need to accept that I'm never going to do it again. And I wasn't ready to be done. So I went back in to the position I'm in now, where I'm a full-time flight nurse with a predominantly adult program that does some pediatrics sprinkled in there. So
He's officially the coolest person ever, who is like who I want to be when I grow up. I I got into NICU years ago and I was like, "Oh, that's where I want to end up." And I just haven't quite picked a path. Obviously in medicine, but haven't decided if I wanted to go into flight paramedicine or go into nursing or anything like that. But so I want to be you when I grow up.
I'll tell you, it took me a very long time to get to where I'm at, and I'm officially old at this point. But I started out. I was talking to my kiddos the other day, and I'm like, it took me 14 years from the moment I decided I wanted to be a flight nurse to actually become a flight nurse. What's pretty awesome is that when I made that decision that I wanted to be a flight nurse, I wanted to fly with a very specific program. And the only reason I went to nursing school was to fly with that program, because they don't fly paramedics. And that's the company that I work for currently. I
That's the
made it.
definition of setting your sights on your goals. Like,
Yeah.
Remember when when I started as a driver years and years and years ago, I was with a horrific partner. He was your stereotypical, had been in EMS for forever, was salty, didn't want to communicate, didn't want to teach, none of that. Mind you, he was like half my size, so it was really funny. But I remember one time we got sent to pick up a flight crew. It was my first experience with a flight crew ever. And bring them to the regional pediatrics specialty center, and they were transferring a kid. I want to say it was for like a liver transplant or something like that. And I remember just being so blown away by how professional and polite these people were. Like, I was in EMT school. I didn't know my head from my ass. And they were just so welcoming and treated me as a peer. And I'm like, I want to be like these people when I grow up.
Yeah.
And no, I didn't do flight. I'm 6 foot, just about 6'3" and just shy of 300 pounds. So
you a big boy, you a salad.
I don't fold well.
Yeah.
So, but I've always appreciated that, and it seems in general has been my experience with flight crews as a whole that they tend to be some of the most professional people in EMS for one reason or another. So tell
Yeah, I
us.
think just to kind of add to that real quick, I think that's one of those things that I've noticed. I agree, right? So a lot of the flight crews, we really I don't want to say PR, but it is almost PR, is a huge portion of what we do, right? So we function, the majority of what we do is in somebody else's office, is in somebody else's space. So we show up at a scene and we climb in somebody else's ambulance. We show up at an inner facility, we are doing what needs to occur in somebody else's ER room or somebody else's ICU room. So a lot of what we do is that communication and collaboration and supporting without coming in and essentially we are coming in and taking over, but we don't come in and just take over. We show up, we help you, we support you. One of the prime examples is like if I'm going to put in a chest tube, oftentimes what I'll do is direct the EMS crew to do the needle decompression because a lot of times that's something they've never done, and talk them through and make them comfortable, include them in that. Or if we're intubating, we use a checklist and we'll hand that off to one of them, include them in there, and work through that. Our goal isn't to show up and just push everyone to the side and take over. It's to work collaboratively. And I think a lot of us, we all started in that area. So we know what it's like. It's not like we just came into work one day and became a flight nurse. Like we started out and grew into where we are. So like we understand the position that those people are in.
Do you feel? I know this varies region to region. I, I guess I'll give you the context for here. There's been such a massive expansion of scope of practice on ground crews around
Mhm.
here in South Carolina, where we have multiple ground services that are carrying blood. There's one place that actually does surgical needle crikes, and there's actually been a lot of issues with helicopter bases shutting down around here because they're not being utilized as much. Is that something that you're seeing where you're at, or are you guys still, top tier enough that you don't really have that issue?
I wouldn't say that the issue is that we are top tier enough. I would say that we don't have enough ground resources either. We're still very fortunate that we have a large number of flight programs in the area, almost to the point that we are oversaturated. But we don't have sufficient ground critical care transport. And a lot of what we do is interfacility. We do the scene stuff, right, where we'll land at a scene and help the fire departments. But we're at a point now where a lot of them are just transporting to the closest hospital and like getting us in the air, and we'll do a helipad rendezvous at that hospital, or they'll take them on in, and then we'll go in and kind of uh, assist from there. So there are some 911 agencies that are having those capabilities of blood and that type of thing, and getting them to the closest facility. But as far as like transporting them to definitive care, there are just not enough ground critical care assets. And I think time and distance plays into that as well, right? So that's where we come into play, where even in areas that have those capabilities, we can still get them there in a much quicker time.
Have you ever done fixed wing, or are you full sold on being on the helicopter?
I did. We did a couple fixed wings, and just because of distance from where I'm at, one of them was, as you mentioned, it was a liver transplant. But it's like an hour and a half rotor flight from where we're at to the facility that does those transplants. So that's a lot of resources as far as like refueling and time in a helicopter and all that. So they used to do those by fixed wing. I that's I had a bad experience on that, and but I only did a couple, and most of what we do now is rotor. I'm not opposed to fixed wing. We just don't have what we see. That used for most often in this area is when families go on vacation and they're somewhere else and something happens, to be able to get them back home and then get them to the facility in this area to continue that care. That's where we see that most often. But we're fortunate enough that most things here can be done by rotor.
Does your agency do both, or is it a separate entity that does fixed wing?
No, so both. So I've worked for two separate programs, and they both used to do fixed wing. And what they would do is they would just charter from a company that offered that service. They would provide the fixed wing and the pilot, as needed. But both of those programs have gone away from it just because there's such a in the flight world, it's such a safety of or such a culture of safety that it's hard when you have someone else bring in an aircraft and a crew that you're not familiar with, and then does our tanks and cords and everything hook up in here, and do they have all those safety things? So there's a lot that plays into that. So it's almost easier to just not do those flights.
With working with pediatrics, I was wondering, do you have a certain age group that you prefer to work with? Like if you could pick your patient, do you have a heart for a certain age group?
Yeah, I think the little ones that are at that point where I struggled with NICU. I struggled with those just because I feel like that's an entirely different world. And I was very spoiled to have a respiratory therapist with me that that was their bread and butter. So I relied heavily on them. So NICU would not be that. But I think the little ones, it's funny. I'm gonna have two different spectrums here. So like the little ones that are they have a personality and they can talk and they're not fully understanding everything, right? To where you can come in and take away some of their fear, make them more uncomfortable, and oftentimes they didn't cause why they're there, right? And be able to kind of support them through that. And then on the far spectrum of it is the older population, the almost the end of life side of it, to where I said if I wasn't so passionate about flight medicine, I would certainly be doing palliative care. I that is a one of the huge things for me is supporting not only that patient but that family through through that transition. And I'm all about quality of life, and sometimes the best quality of life is end of life, and helping support them through that. So I think that's where and if you've seen any of my stuff, and I'm huge on family centered care, and so I think that's why both of those kind of play into that, like in being able to take care of not only the patient but supporting the family through that as well is a big piece of my passion.
Honestly, when it comes to education, I harp a lot, even with the new EMT providers coming in, about how to deliver death notifications and how to take care of family members as long as they're not hindering care. And I feel like that's something that really should be harped on more in education is delivery of death news because that family is going to remember your face and probably your voice for the rest of their lives. And I think that's wonderful because
Absolutely.
not everybody can communicate and comfort family at the same time as providing care to the family member or to the patient. So that's wonderful. I'm right there with you. I'm unfortunately very good at death notifications and comforting family.
Yeah, so a couple things there, right? So the death notification part. So Alex Jabber has a phenomenal death notification course that she had that experience where she felt like she didn't handle it appropriately when I believe it was when her mom passed away, and like notifying the family and all that stuff. And so she has a phenomenal course on that. But the as far as like including that family and having those conversations, like they absolutely 100% should be involved. And I've and just included in there, and that does not impact care. It's what people providers have to understand is that it's not about our comfort level in that moment. We may be uncomfortable, and that's fine, but it's not about us in that moment. It's about supporting that family and that patient through that process, and having them included and be aware. It's absolutely instrumental in the care, and that's. I recently sat down with Dr. Antevi, and we talked for I think we had an hour and a half scheduled, and 2.5 hours in, I was like, I gotta let you go. Like I was like, I want to be respectful of your time, but I'm really enjoying this in exchange. And that's one of the things he came back, he's like, he goes, the things that we discussed today are the things that I don't normally get to talk about. We don't normally talk about like those nuances. He's like, I would love to come back and dig deeper into some of these subtle aspects of care that just aren't discussed anymore. So I agree 100% with that, including that into that education, and teaching our new up and coming EMTs and paramedics that it's absolutely instrumental in the care that we provide. And you will feel better at the end of the call, and that patient and family will feel better at the end of the call.
Well, I mean, not to get dark, but I mean, including family during a cardiac arrest, like maybe not having them necessarily do compressions unless they want to, but don't kick them out of the room. Let them watch. Let them hold, a liter bag of saline. They feel useful. But that way, if you have to call time of death, they understand that you did everything. There's not a mystery behind them, is to the result of the arrest. As long as they're not, screaming, yelling, throwing, shoving, then that's a problem. But that again could come down to a conversation.
No, I mean, I think that especially if you have family that is cooperative, they're not flying off the handle, which especially in peds is hard.
Mm.
Is very, 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 very hard. But even if you can have one person that is kind of like the designated representative, I feel like that makes a huge difference. And I've I feel in general for our interactions with peds, 90% of it is parents that are scared and the kid's actually fine and there's not anything horrific going on with the kid most of the time. And I think a lot of people get frustrated with that, especially newer providers, because there's like, oh, this isn't that big of a deal, but they don't think how to talk to the family. And I like that. And I want to dig into that a little bit more because I like your approach of family centered care, especially for pediatrics on a whole.
Well, so that actually kind of brings to mind a call that actually made the news in one of the counties near where we live about a pediatric baby. It was neglect on the parents. So, baby basically was left in the crib for days, got hypothermic, and was eaten by field rats, like fingers, toes, like all the tips of the body. But the biggest thing is it's not just the anxiety of new providers. The paramedic that ran that call was a very experienced paramedic and ended up calling for ALS backup, who then also in turn called for ALS backup. So you had probably 60 years worth of three paramedics on that truck with no ALS interventions. It literally just turned into they weren't quite sure what to do. And don't get me wrong, that's a horrific call. I don't know how I would handle that call personally. I mean, pediatric calls in general don't bother me, but in general, how do we communicate with our providers that maybe are uncomfortable with peds calls, no matter how new or old? I mean, 60 years of paramedics on one rat bite baby call is, I mean, that's a lot.
Yeah. So, two things, right? So, to kind of go back to what you were saying initially about having family involved in resuscitation, I agree 100% that they should very much be at least present. I don't know about involved as far as interacting, but they should 100% be present. There should be somebody assigned to them that is explaining everything that is going on. This is what's happening. This is why we're doing it, and explaining that process. That is absolutely instrumental. The evidence is there to support it, and that is including pediatrics. Right? We need to stay on scene. We need to do high quality resuscitative measures. Right? So that absolutely. Now going to the 60 years of experience and still under treating the patient, right? It is, and that is what my entire platform up is about. And those are the things that I talked with Dr. Antebi about. Is it's all about improving, reducing that pucker factor, but improving pediatric care by improving pediatric readiness. Now, and you do that by educating and including pediatrics into your everyday stuff and making it the norm, knowing that pediatrics is less than 1% of the call volume for some agencies. So those 60 years of experience may have seen two, three pediatrics in their entire, at least sick kids in their entire career. And but the expectation is that they still show up and provide that high level quality care that they provide for the adult patients every single day. And there's Dr. Antebi speaks to this, like we've separated everything out where we have pediatricians and then we have pediatric cardiologists and we have pediatric kidney docs and pediatric dentists and pediatric orthodontists. And then we have adult, right? The geriatric. We don't have that ability. We are everything. We have to be able to
Yes.
cover all of those. We never know what that call is going to be. So we have to be prepared. So we understanding and breaking down those barriers. I say this all the time, pediatric patients are undertreated. It's that error by omission, right? So we're not treating the patient because we're not comfortable. We're not confident in the treatment of, yeah, they probably need a treatment, but I don't, I've never done it. We're only 5 minutes away. They'll be okay. I'm not going to start this fluid, or we're just going to grab this floppy baby and treat with diesel and get to the hospital, because all of a sudden, as soon as I get through those doors, they're going to get everything they need. And I did best by this kid by just getting them there. Absolutely not. So we have to, one, reduce that pucker factor to where people don't show up stressed, right? They don't show up with that heart rate through the roof and they're already shaking, and they don't, and then they walk in and they see this floppy kid. Understand that those algorithms to treat that cardiac arrest pediatric patient is the exact same algorithm that we're using in the adult patient. I understand it's a high stress situation. And that's why I start every video of, does this make you nervous? Do you get nervous when you have to do this? So do I. But let's talk about it, right? You can still have some nervousness, but how do we control that nervousness? How do we kind of not bury it down, but make it to where it's not so bad by having a plan in my head already? I'm offloading all that cognitive load by using resources, and I'm calculating things before I get there. So when I get there, I'm not having to make decisions in the moment. I've already made those decisions before I got on scene. And I'm calculating all that out. That way, as I walk up, I'm not, oh shit, where's my Brazo tape? Well, how long are they? What now I'm calculating what I already know what my tube size is going to be. I already know what my first dose epi is going to be. And having that confidence changes the game. It changes the game. It absolutely does. So we have to understand, and I've been guilty of this too. We have to understand that pediatric patients, while we've always said they're not just small adults, they kind of are. In the fact that we treat them the same way. And again, there are anatomical differences. There are age development milestones. Those things do change. But the treatment itself is the same. So we have to understand we're doing the same treatments with minor little variations in there.
Mhm. Well, I love that you talked about Dr. Hentevi. I love that man so much. I love talking to him, or excuse me, I love listening to him talk, to teach, all that. Have you gotten to use the new updated Hentevi app?
Yes, I use it. So I use it all
Thing
the
is,
time on, I use it for both pediatrics and adults.
I love that
Uh,
feature.
yeah, I use it all the time to be able to go in and then able to pull up policy, the protocol and everything in there. Absolutely.
So I'm OCD enough. I tend to not use it on a cardiac arrest. However, have you gotten to use the cardiac arrest feature where you can alternate and keep track of your airways, your epi, your defibrillations, the pulse check? Like, they have done amazing things with this app. I will say that.
Yeah, I have not got to use it in practice. I've played with it. I guess, knock on wood, I have not had any
Yes.
arrests,
You're
but
screwed
also,
now.
so, and I think that's part of what being on the flight side is, because we don't fly those patients. Now,
Yeah.
sometimes we'll show up at a scene and support, like in a traumatic arrest or something of that sort, and either called at the scene or get ROSC and transport that patient. But those are few and far between. And while we do manage a lot of sick patients, we're fortunate that we have a lot of resources at our disposal that allow us to manage those and treat those patients. And so we don't deal with the arrest situation a lot.
Mhm.
But I have played with it, just checking it out. And I'm like, this is on point. Like, they really did it very, very well.
I also like that it timestamps.
So
So do
since
you
we're
have the feature that it uploads into your charting system then?
We haven't connected it yet. I'm a training administrator at one of my jobs, so I just like approved all of our protocols. But of course, South Carolina just updated our protocols and made it actually quite expansive. So I haven't released it to all of our service yet. We're looking at getting it integrated into charts, but that's going to be like one of the last things that we do after training and everything else. But I have to finalize all the protocols first.
Yeah, I think that will be a real game changer as well, right? When you're going through and able to timestamp and in real time chart those things, and then you just upload it like your vitals, and then all of a sudden it's in your chart, you're like, oh, this is fantastic. So
Right now at my station, my monitor doesn't transmit, so a cardiac arrest chart takes me like 3+ hours because I have to manually put everything in.
oh yeah, that's no bueno.
No, no, it's not. I
I
love medicine and I don't mind doing a cardiac arrest, but with my current monitor, I it please be gone.
so I transported I worked Christmas Eve and then I worked Christmas night, and I ended up transporting a mid 40s cardiogenic shock post arrest that had an Impella device and had an art line and a swan and was on like 5 different drips. And going through and trying to chart all that, I could not imagine trying to put in all those vitals and all that stuff. So I feel you on that one.
That's a complicated patient, man. That patient had everything.
Yeah.
Makes my brain hurt just thinking about it.
Yeah, we went from one ICU to the other, and it was it went very well. We were able to get them safely there, and there's a lot of things to consider, and it's all about logistics at that point of trying to get all those lines and the Impala device and all that stuff, and get them moved over, just only hours after they arrested, and then bounce them down the road
Yeah.
and manage all that. But it was one that went very smoothly, and the charting wasn't terrible because everything got to upload.
Well, so with everything that you do, up in the upstate, one of the services that's the most advanced, critical care service in the upstate of South Carolina, they have entered into ECMO. Is that something that you have experience with?
So we have the capability to transport those patients. We have. It's not something that we routinely do, but we have that ability. But we always take a perfusionist with us if we do those. And so those patients end up coming down where at that point it's mostly about logistics, safely getting them transferred and moved over, and making sure the lines don't get pulled, obviously. But essentially those patients are stable in the idea of that all everything's being done for them, and they're pretty much stabilized out at at that point. So while it is a lot of logistical manpower, the patient themselves are pretty stable.
So with switching gears a little bit, with where your channel was 2 months ago, last time you and I had really sat down, what are the biggest changes that you've had as far as positive growth and maybe things that you've learned about how to adjust your approach to content creation? And, what's the biggest changes that we've had since then?
Yeah, so it's interesting. I've had a significant amount of growth as far as like followers, and as far as like people reaching out to me, sending me PR stuff or books, or books to review, or just little swag bags or that kind of stuff. I've had more of that. I've had more people reach out, and I've got accepted to speak at more conferences. And I honestly, in the last, I don't know, month or two, I really have not posted much of anything. Like I still go in when people that I follow are live, and I try and go in and support them and do those things and interact a little bit to support them and just continue those conversations. But it's interesting. I've continued to have growth while not doing a ton, uh, but I'm growing in different ways. So I'm doing more education stuff and conference speaking than the TikTok itself. And I I think coming into the winter, it's very hard to stay consistent on there and post as much as you need to post to stay as relevant. And I've really struggled with that, and it's I don't know if it's the holidays or the winter weather or what, um, but I feel like I just haven't been as motivated to do it. And it's interesting because like things are still growing, things are still happening on the back end, but I haven't really participated. I haven't really contributed to that. And I don't know. I think I've just been in that like end of the year funk, the holiday season and that type of stuff. But there is so much positive things going on around me, uh, for me personally. Um, but yeah, it's weird to kind of step back and not make as much, not contribute as much, but still feel like I'm having an impact and growth because I still log into people's lives and they're like, "Oh, the Blakery content's in here," and they kind of rant and rave about how awesome I am, and I'm like, "Man, my head's not going to be able to fit through the door to come in here if you guys keep this up." But it's been interesting because I like I say, I don't want to sound ungrateful because there's so much positive things happening for me right now, but I feel like I've still just been in this like end of year rut funk of not feeling super motivated. I don't know.
Well, I mean, ideally, what do all of us want? We want to see good change in the world around us. So even regardless of the TikTok numbers, if the engagement is actually there and the positive growth is there, that's more what matters ultimately.
Yeah.
Tell us more about the podcast? Because I know you'd referenced it before. And obviously you spoke with Dr. Antevi. I've seen bits and pieces of that. Haven't gotten to watch the full thing yet. Um, what are your plans with that? What do you have still coming forward with that?
Yeah, so that's another thing that it kind of started out natural, just like a natural progression of growing on TikTok and doing that. And I don't know that it's going to truly grow into like a full, consistent, reoccurring podcast that's, like people are going to go out and search versus more of me just having genuine, raw, authentic conversations with people and calling it a podcast and uploading the full discussion to out there into the world for those that want to sit down for 2 hours and listen to me talk to someone. But I think what will probably mostly come out of that will be the smaller chunks of the little clips that I've posted recently of like interviewing Dr. Antevi. So he was the first guest, which is a pretty huge inaugural guest for the to have on there. So it was, and as I spoke with him and the way it played out, like again, I don't know that that's something that someone's going to want to sit and listen to for 2 hours, but I think there are chunks of information in there that can be broken down into those smaller, digestible reels or shorts or TikToks or whatever to get that information out. So I have several other people lined up that I'm going to be interviewing, but really the goal with it was to interview high level pediatric providers from across the country and just have dialogue with them about what do they think is important in pediatrics and neonatal currently and what are the things that they see that are current and prevalent that could impact the care that EMS provides and reduces some of that pucker factor for providers that don't see pediatrics all the time. And that's really everything that I'm doing. That is the goal, is to just make improve pediatric patient outcomes by improving the confidence of our pre-hospital providers. And so some of the ones I have lined up, Dr. Tracy is a pediatrician on TikTok who she'll go live for hours, and new parents can log in and ask her questions, and she does a phenomenal job. And she's like, I feel intimidated to speak to you as a pediatric and neonatal flight nurse. She's like, I don't know that I can actually bring anything to the table. And I'm like, you 100% can. And we can talk about the things that she sees in doctors' offices, and what are the things that EMS could do better, and interacting with these kids, and like what's normal versus what are the normal things that people may call 911 for. And just kind of, again, breaking down some of those barriers and uncomfortableness. And so I have Nurse Hens, who is a nurse practitioner. She's a peds and neo flight nurse out of Florida, who does a phenomenal job. And again, just talking to her and breaking down some of those concepts of like, all right, when we talk about transporting a pediatric patient, what's important to you? What are the things that you're thinking about? What are the things the hair on the back of your neck stand up? And you know, I think anytime that we could break down that sick versus not sick, and share that with those providers that don't see it all the time, so that if they get a call and they're like, oh, this kid looks great, and then there may be one little red flag, and they're like, wait a minute, somebody said something about this might be something, right? This might be why they're calling me out at 2 o'clock in the morning, and the kid looks fine and I'm irritated about it, right? And then it's like, oh, that's right, these are the kids that we find dead in their crib the next morning because something is going on, even though they look great in this moment.
From a from an education standpoint, and speaking specifically of both EMT and paramedic education, what are some things that you would like to see happen in that are focused on peds that we're really not doing right now?
Yeah, so I think a couple things is incorporating them more into the entire curriculum, versus just this small little chunk of time in the session. And so when you're talking about airway, include pediatrics in the airway, because if we treat an adult asthmatic and then we talk like this is how you treat an or a pediatric asthmatic, and oh, look at that, it's the exact same treatment. And then at the end, be like, okay, so here's the caveat. Here's what's different in a pediatric patient, right? So we're doing all of this the exact same, but here's those subtle differences. So incorporate that all in. So you already have your mindset of, okay, I'm doing the exact same thing I'm doing for adult, but I also need to consider this or watch for this or not do this. Okay. So anytime you can tie that and incorporate that in, there's a program here in my area that has done that, and they do peds throughout the entire year, and they actually do 60 hours of clinical time at the regional pediatric center. 60 hours of peds clinical time. And when I was running that, I got them, they were going into the NICU, they were going into the PICU, they were going to the ER, they were spending time with the respiratory therapist, they were spending time with the nurse, they were spending time with the pediatric ER physician. And we got them everywhere. And just again, and I would stress with them, it's not about how many skills you can do, it's about as much exposure to as many patients that you can get, and understanding that sick versus not sick so that you can start to see what those kiddos look like. We'd send them to the NICU and have them feed feeders and growers. Some of these kids have never picked up a baby, and they get
Yeah.
to pick up a baby and hold them and feed them. And this is what a kid looks like when they're doing great. And then next room over, this is what a kid looks like when they're not doing so great. And these are those differences.
Well, Daniel and I both went to the same program. When I was in paramedic school, it was kind of post COVID, or well, it was technically during COVID. pick a timeline. So during the program, I wasn't able to go to a lot of these specialties, but I was hired and actually started teaching straight out of paramedic school. And the longer, I was teaching and got my credentials and all the rest of it, I was approved to do hospital clinicals. And with my background, I was actually the only one on our staff that was allowed to take students up to the NICU, OB, pediatrics, all that kind of stuff. And it was just amazing to see the students interact with these babies. It was really nostalgic and kind of a comfort for me because I had previously worked in NICU and OB, high risk OB, all that kind of stuff. I worked at a 3B NICU. So, like, we didn't have surgical capability, but we could take care of the micro preemies. So, it was really cool getting to share that with students and see it kind of clicked with them that, like, hey, this is, a tiny human, literally, but get to see that firsthand. So maybe they're not as shocked. And as for the experience, I mean, I've been on calls with anxious parents that I had one family that called us out for projectile vomiting, had a history of GERD. And I started talking to the family, just asking questions, have you gotten a tongue tie or lip tie? Have you gotten a swallow study? And they're like, oh, we're just going to a general practitioner. They haven't mentioned any of this. And I was like, well, caveat, I'm not a doctor, but in my experience, maybe discuss this because I mean, they tried like 10 different formulas and there was no improvement. And I was like, you need a swallow study.
Yeah.
So what do you see with I really enjoyed when you and I last talked. We talked about the mental health and specifically mental health in dealing with peds. I want you to go over that again, and just I want us to actually have a longer discussion about that. So tell me, especially when you're interacting with newer providers and educating them on this, your approach to managing mental health while dealing with really, really, really sick kids.
Yeah. So there was, and I think we talked about this in the last one. There was two things that were told to me very early on in my career. And again, I started out in 2001 before mental health was one a thing or even remotely allowed in the fire station. Right, like it was just not something that was thought of. It was always you signed up for this, just choke it down and move on to the next one. But very early on, because I had one of the first auto accidents I went to was a quadruple fatality accident. And I was 20 at the time, and the occupants were between the age of, I think, 20 and 26. So they were all very close. Two of them were brothers, and the other one was the third one was their sister's fiance, and she showed up at the scene. So she lost her two brothers and her fiance in that moment. And these were some of the worst patients that I had, as far as traumatic patients that I had seen. And in my entire career, it happened within the first few months of me being on the department. And I really struggled with that starting out. Like I remember everything I would go do, I was like, you know, I would go get in the shower. I'd be like, well, they're never going to do that again. Or I would just, anything I would do, I'd be like, well, they're never going to be able to do that again. Or Tony Hawk on the original Xbox was a game at the time. And when you crashed, there would be a smear of blood across the screen, like a very fake red smear. And I couldn't play the game. Like it just it just kind of bothered me, and this went on for a little while. And I remember talking to I don't remember if it was the same guy or two different people told me, but you know the two things that were told to me then and have stuck with me throughout my entire career is just talk about it. The more you talk about it, don't bury it down, but the more you talk about it, the more you express it and talk through the situation, the better you're going to be. And the other one was once you can grasp the fact that you didn't cause it and you were just there to try and make that situation a little bit better and do everything that you can to make that situation a little bit better. And again, that was in 2001, very early on in my career. And those two things have stuck with me. And I've done those two things ever since. And I've been very fortunate that I don't know that I've had any calls there are calls that live with me and will live with me forever, but I don't feel like any of them have bothered me to the point of like that first one, right? So I think by implementing those thought processes has changed how I respond to these occurrences. Now, obviously, when you bring pediatrics to the world or to this conversation, I think that changes things, right? And the fact that we are already high stress going into it. And the way that I combat that and address that is by confidently walking into that scene, knowing that I gave that patient the best potential opportunity at a positive outcome. I walk away every single time knowing, and Dr. Antavi and I talked about this as well. I walk away thinking, I crushed that. I crushed that. That outcome was not the desired outcome, but I gave that kiddo every possible opportunity at having a better outcome because I was on my game. I was prepared. I was ready. I was confident, and I performed at a high level. And that allowed me to walk away saying that there was nothing that could have changed the outcome for that kiddo because I truly did everything that I could possibly do. Now, part of that is the level in which that we function, right? My protocols or the system in which I function, I can do chest tubes, I can start blood products, I can do RSI or whatever it may be, ventilators and all that stuff. So I have a lot of additional resources at hand, but I can confidently perform those skills too. And that's what changes it for me. And when you can walk in and know that you rocked it, you crushed it, you walk away with a different mindset, regardless of the outcome, because you're like, you know what? I didn't cause this. And I truly gave this kid every opportunity to have a better outcome. And that just wasn't in the cards today.
Go ahead.
Sorry. I was going to say there's so much truth to what you're saying because it as you were speaking it you can call it a flashback, a memory. However, there have been times where I will obsess about a call, not knowing the outcome, and have to talk about it repeatedly. And I feel like us talking about it kind of takes away the power of the situation by talking about it, talking through things. And I mean, there was one call that I actually called my training administrator at my other job that I'm, a street provider at. And I talked with her and Daniel repeatedly about this call. Now, I've had calls previously where when I find out the outcome, I'm like, holy shit, I treated that incorrectly. But it comes down to you treated and did best for the patient by treating the ABCs with what you knew. We can't do blood work, we don't have scans. And there's been a couple calls that absolutely fell to shit, but ultimately by treating the ABCs, doing what we could with the situation, and then finding out the income, the not the income, good lord, the outcome. It's like I had one brain bleed lady. She had four different brain bleeds, including her brain stem. Do you remember that call? It ate me up for weeks.
Vaguely.
It was the GI bleed, or excuse me, the bowel obstruction that I tubed. The RSI went absolutely south. It was a hot mess. But I thought, maybe she was hypoxic. I killed her brain because there was issues with the airway, and then come to find out she had four brain bleeds. I was like, oh, so I prolonged her life. Family got to say goodbye. So
Yeah.
there is so much truth to what you're saying, so much so.
Well, and I'm sure you've seen the movie Bringing Out the Dead. That's just standard issue. But one of the lines from that I think has actually stuck with me quite a bit is where main character says that our job is to bear witness. We're there. Yes, we have a job to do. We have skills to do, but we're bearing witness to so many things because you can have and I preach this to new people all the time. You can have two completely identical patients, genetically identical, same, medical history, same presentation, same issues. You treat them exactly the same. One's going to live, one's going to die. you don't you can only do what you can do, and like you say, have the confidence that I put everything out on the table. And once you do that, you just sit back and sometimes just watch it unfold. And I think from a mental health standpoint, that helped me a little bit because it took a little bit of the pressure off of me to say, hey, as long as I'm doing what I'm supposed to do, I I'm not I'm responsible for what I do, not for what happens after I do the right thing.
Yeah. And I think the idea of treating a patient and interacting with them, eh, you know, the idea that, sorry, I'm trying to think of how to say that correctly, is the treatment doesn't always have to be 100% on. What we have to do is we have to, you know, take into consideration what we have in front of us and do the best of what we have with the information we have and the resources we have, right? So what being able to walk away from a patient that all you were able to do was one intervention on a scene with a 911 call is completely different versus me showing up in a helicopter with an advanced practice and a ventilator and all these tools and toys, right? Like the perspectives change and the priorities change too. So I think one of the things that I hear oftentimes when I'm out teaching is, a simple fluid bolus. When I talk about a fluid bolus and I teach how to do a push pull fluid bolus and fluid resuscitate these kiddos, and people oftentimes are like, I don't have time for that. I'm doing all these this or that. And I'm like, listen, like what you have to understand is the priority here is that fluid bolus, that fluid resuscitation. All that other shit can wait. Like if that's the only thing that you do, this is what's going to change the outcome for that patient. Getting that IV or IO access and getting that fluid bolus in. Like all the other things that you want to do can wait. So it's understanding what those priorities are with the resources that you have available in those moments.
Well, and doing, like you said, doing the little things correctly is, so much of it we treat as monkey work, which some of it is. I mean, to me, like how I start my IVs, how I, prep my airways and whatnot. A lot of it is just rote skill, rote things you do. But focusing on doing it properly, prioritizing it. We just actually had an interview with. Have you seen the videos of the EXG device? It's the like single pad of stickers that then you just kind of pull them up to proper placement on the patient. It's just like a one time.
Oh
So
my goodness, it's so fascinating.
I'll send you the video for it shortly. But these two
Yeah.
docs out in California came up with this, and it's meant for everything from pediatrics to full sized, even bariatric adults.
Pre-hospital and continuum.
Yeah. It's meant to basically be you stick it on them, ideally pre hospital. It is designed for proper placement. It stays with the patient all through their care. They said they've tested, they've worn it for up to a week straight.
Working out, showering, all of the things.
And a big drive for why they did that, and they provided a lot of the data behind it, is because the you can mess up your EKG placement by you literally just by an inch, and you can completely miss a STEMI. You can miss so many different things.
The statistics they showed on how often an anterior anterolateral STEMI is missed made me ever so slightly paranoid.
I'm really self-conscious about it now. But that's a skill that, I mean, how often do we think about making sure that we do 100% proper placement as best we can?
Almost
We're
never.
usually just slapping it on them. But so their mentality was, okay, well, let's systematize this. Let's actually literally create a device that's, for lack of a better term, idiot proof. They didn't say that, but that's what I take from it. And because it's that little thing that we don't think about that can dramatically impact a patient's life forever.
Yeah, but
And so I
what it
agree with
also
you. Yeah.
does, yeah, what it also does though, is it reduces that, it offloads that cognitive load. in that moment, because now you're not having to think of like, where do I put which ones, where does this one go, and that. So anything that you can do to offload that cognitive load and streamline those processes and make you feel more confident and comfortable in knowing that you're performing that skill to the best of its ability, like that changes how, getting back to the mental health side of it, that changes how you walk away from that call, right? If you show up and you perform, like if you go to a call and you get that the first IV immediately, first attempt, no issues, you progress to intubation and it's a beautiful first pass success with uh no issues. Like you walk away from that and you're like, I just fucking crushed that. Like I'm kind of a badass, right? Like that's how. So we have to do that with pediatrics too, in the fact that it's not just, oh, well, I don't ever deal with pediatrics. I'm just going to sit here and clench my butt cheeks while we drive to the hospital and hope this kid doesn't arrest on me. So it's being able to do those interventions and feel a little bit more comfortable, because I guarantee you that if you have that sick kiddo that you're just sitting there watching being sick, and then you drop them off to the hospital and maybe they're a little bit sicker, maybe they're the same, you're going to walk away from that and that call is going to sit with you. Now, if you show up and that kiddo is lethargic and not tracking, and you have the confidence and the ability to start that IV and to give that fluids, and then you transition and you transfer that kiddo over, and that kiddo is now smiling at you and they're tracking and you're following, and that mom and dad leans in and says, that's my kid. There's my kiddo. Right? Now you're going to walk away and be like, okay. Okay, right? Like those are the things that change, and that's how you can change, and that's where I talk about, reducing the pucker factor. It's not just about building a little bit of confidence, but it's also preventing burnout and that mental health struggle on the back end, because you now walked away thinking, I just confidently and successfully handled that patient. And it changes the way that you walk away from it. It takes away that long-lasting impact.
Well, and it just kind of, I was just sitting here thinking too, how often do we see providers, and I've done it at different points in my career too, when I've been more on the burnout spectrum, if you will, where we'll want to take shortcuts. We'll want to maybe not be as precise as we should be. And we blame it on, our poor mental health. And yet, if we put in a little bit more effort, a little bit more time to do things the right way, we'll see the positive benefits to our patients. And that's going to give you a dopamine hit to see that, hey,
Absolutely.
I actually did a good job and I should do that. So we're kind of shooting ourselves in the foot with it, honestly.
Absolutely. And I'll tell you, I'll try to say this in a roundabout way without giving too much information. But I had a transport the other night. Now this was an adult patient, young adult, very young adult, and we get called out as a critical care team. And it's late in my shift on a night shift, so or take it back. It was a day shift, but it was late in my shift. I was going to get off late, and holiday things were, we had plans and things were coming up, and I was going to get off late, and I was already irritated. And we're going to an urgent care that typically we don't go to anyways because we're a critical care team. And the concern was for a potentially intoxicated, concern for potential trafficking, uh, domestic potential case. So again, I'm I'm pissed. I have an attitude. We on the whole way there, I'm gritting my teeth. I'm frustrated. We get there and I walk into the building and the staff greets us and I'm irritated, almost dismissive. And I walk past them and I start walking down the hall to find out the room that they're in. And I'm probably 2 or 3 steps away from that room. And I just had this like instant, like gut check of like, listen, your attitude and demeanor is going to make or break this moment. Like the way that I go into this room and enter into this room is going to set the tone for the entire transport. And I will tell you that in that moment, changed gears. I immediately switched gears and I went into it the way I should have went into it. And I checked everything else out. And I will tell you that it was a bad situation for this patient, right? This patient was in a bad situation. And this patient, on the way to the hospital, we were interacting, we were having a phenomenal conversation to the point, like, we get there and, like, the patient is panicked and anxious and tearful and confused to we spent 20 minutes on the way to the hospital of this patient just sitting there comfortably smiling, laughing, conversing with me the whole way. To one point, this patient looked at me and she goes, I have never, no, not never. She goes, I have not felt this safe and secure in as long as I can remember. And I'm like, I'm glad I didn't walk into this room being an asshole because that's the last thing that you needed right now. And it was one of those like, and even the partner, the partner I was with, they joke with me all the time. Like, we'll go into places and they'll interrupt people and be like, hey, this guy's TikTok famous. Do you know you're talking to the Blakery content right here? Like, no, that's, so, uh, so, so we will, we were on our way back and the medic I was with, he was just like, he was like, he's like, I'm so glad that the Blakery content was here. He's like, I'm glad I got to witness that because he's like, that was fantastic. And it literally was a switch. Just, I flipped a switch and I took myself out of it and got to be there and support that person and to have somebody in that situation who, you know, honest to God, looked at me and smiling and laughing and felt like a normal human being for 20 minutes on this transport and was like, I have not felt that safe and secure in a long time. And it's just like, we are invited into some terrible situations, invited in, and we get to the, this sounds very Chick-fil-A, but we get the, we get the, ability to show
it's
up.
the pleasure.
The pleasure, right? The pleasure of showing up and supporting these patients and impacting their lives, for 20 minutes at a time, an hour at a time. And as cliche and cheesy as that sounds, I walk away feeling a lot better because I didn't show up like an asshole like I wanted to and supported that patient and just took myself out of it and gave them what they needed. And I don't know. I go to sleep at night very well knowing that that's the interactions that I have with my patients. And maybe that is going the extra mile because there was not a time. There was a time in my 20s where I was that paragod. I was the one that showed up and I was like, they're like, can I get shoes? Nope. You can walk. Let's go. We don't have time for that. Like and part of that is maturity, part of that is growth, and part of that is experiencing the things that I've experienced. But we just got to get to that point that we understand how privileged we are walking into some of these situations that are just the absolute most terrible situations for some people. And they look to us to impact that and change it.
I thank you so much for sharing that story. That's the kind of stuff that we need to talk about more because we're always going to have the asshat patients. We're always going to have the jerks at sending facilities. And even if you're nice and receive the ugliness back, we know that we put our best foot forward. But the calls that you're talking about, even if I'm having a bad day, if I can just make one little grandma smile and joke with me, that also helps with mental health. If we go into every single call looking for a fight, and if we get a late call going into it looking for a fight, well, one, you're probably going to get a fight and you may enjoy fights or you may not.
You know,
But but that may be okay, not okay. That's the wrong word to use, but like you may do that occasionally because everybody has a bad day. But so many of us, I say us, not to sound arrogant, I don't go into calls like that. But there are times in everyone's careers that you're going to have a bad day. But as soon as it takes over and becomes a culture and because becomes your personality, it decreases patient care, and I'm sorry, exactly like what you're saying, it affects your mental health. So of course you're going to get burnout. And it's exhausting when you have, the repeat frequent flyers, and Lord, that's a whole other discussion. But I'm so glad that you were able to make that person smile and have a good experience because that's what makes the bad shifts better.
I think I knew I hit a point of quote maturity in my career when I became more focused on how can I make this call positive experience all around, even if it's bullshit, even if there is no reason for us to be out there. When I can walk in with the mindset of I want to make this a pleasant experience as much as I can for everybody, suddenly that stress, the angst of, oh, why are we out here again? Oh my God. Like all of that just poof, it goes away because your focus is different. You're not looking for a fight. And yes, I enjoy a tumble as much as anybody else. It is cathartic, it is fun, but I like it to be well deserved, not something that I started. Um, yeah, I think that makes a difference. Yeah. Well, Christopher, I appreciate you coming on with us. It has been a pleasure. I can't believe over an hour has gone by already.
Really, that went
Any
so
parting
quick.
thoughts? I know. Any parting thoughts, shameless plugs, whatever that you want to throw out there for everybody?
I think the final thing for me is just get more comfortable and more confident in providing that pediatric care. As Dr. Antebi mentions, the error by omission is just as significant as the medication error, right? Of giving the wrong dose. By not treating your patient because you're not comfortable and you're not confident when they need that treatment is just as significant. So, just building that confidence and being more comfortable around pediatrics. And if you're not comfortable and you're not confident, like I get called all the time. They're like, "Oh, you're the pediatric expert," and I'm like, "I'm no expert by any means. I've just been exposed to it more, and that's all it is." So if you're not comfortable, get more exposure. Start taking more classes. Find every pediatric CE and education that you can and just build on that and become more and more comfortable and confident.
Well, it was a pleasure. I'm sure we'll see you around more. Hopefully, we'll run to each other
Sure.
at conferences sometime in
Yeah.
the near future, sometime soon. So, thank you, brother. Appreciate you. You be safe. Have a good day.
Yeah. Thanks for having me. You too.
If you enjoyed this episode, be sure to follow us on YouTube at Paramedic AF, or you can subscribe on Apple Podcasts and Spotify at the Paramedic AF Show. You can catch up on the Daily Debrief, kind of a sub-show within the Paramedic AF Show, or you can watch our full-length episodes, including interviews and discussions on leadership, culture, personal wellness, mental health, everything related to daily life in EMS. Make sure you hit like and subscribe.